Good morning.
So shall we start?
Yeah, I'm good.
Yes, sir. Good evening, everyone. Welcome to Mahamana Case Discussion Series. Today we have with us Dr. Arvind Krishnamurthy, sir. And today he is going to give a talk on the... Just a moment. Sorry about that. So today we have with us Dr. Arvind Krishnamurthy, sir. He's a professor in surgical oncology from Cancer Institute, Adyar. And today he's going to give a talk on the promise of neoadjuvant immunotherapy in head and neck cancer.
Volumes varadillappa. Arvind, volumes varadillai.
Yeah. Can you hear me, Sunena?
Yes, sir, we can hear you.
Yeah, okay. Can we get started?
Yes, sir.
Yeah. Thank you, Azim. Thank you, Sunena. And thank you, everybody at Mahamana. I think it's a pleasure to be here. I think I put myself in a very difficult space to speak about topic of immunotherapy. But people might be wondering why like, a surgeon needs to sort of, know all these things, but I guess, the landscape of management of many solid cancers are changing. For example, neoadjuvant immunotherapy in the driver negative space of lung cancers have become a new standard of care. And slowly it is creeping in many other solid cancers as well. So, as a member of a multidisciplinary board, it is important for all of us to sort of, have some working knowledge on all aspects of the traditional modalities of treatment, including immunotherapy. And I will give you some surgical perspectives on the scope of immunotherapy in resectable head and neck cancers. Uh, of course, this talk will be tailored only in the locally advanced space of resectable. The world over, the problem is of HPV positive cancers, but we know that our burden of HPV positive cancers is much lesser. Our burden is basically the HPV negative cancers, and especially the oral cavity, larynx, hypopharynx cancers, which become a great therapeutic challenge for us. A lot of things have not changed over the last 20 odd years. Surgery and radiation therapy with or without chemotherapy. And this has continued ever since the time I started or I did my master's in surgical oncology. So way back in 2004, you had those path-breaking trials, the RTOG and the URPC, in a high-risk cohort of patients, suggesting that you could sort of add chemotherapy to radiation therapy in the extranodal and the margin positivity. After those publications back to back at the NAGM, we didn't have much to offer in the locally advanced space of head and neck cancers. We know that immunotherapy has got a very clear and established role in the recurrent and the metastatic setting. We also know that a lot of attempts have been made to study the immune checkpoint inhibitors in the earlier settings, like the locally advanced settings, in the adjuvant space, in the concurrent space, and more recently in the neoadjuvant space. But till 2025, almost all of the trials have been negative. But of course, things are about to change with a couple of positive readout trials, which I'll be trying to highlight in subsequent slides. So we know that in the metastatic space for patients who are not amenable for surgery or irradiation therapy, of course, you have the immune checkpoint inhibitors and you make the decision based on the platinum sensitivity, the tumor and symptom burden, PD-L1 by the CPS score, and the performance status. Of course, the mandate of the talk is not to discuss about the recurrent metastatic space, but this is how we tend to go about in the management of some of these patients. We know that immunotherapies are relatively costlier, and triple oral metronomic therapy seems to work as well in our setting. But what about the evidences when it comes to the use of immuno-oncology agents in locally advanced spaces, especially in the concurrent and in the metastatic settings? We directly dive into the evidences that are happening. These are important trials. These are some negative trials, but nonetheless, these are very important for us to know. So I will be quickly going through some of these trials. Since it's a lot of trial-based data, I will try to quickly go through it and try to give you all a flavor of what the trial really wanted to speak about. The first important trial is the Javelin 100 trial. These were patients of locally advanced head and neck cancers, HPV positive and negative, basically stages 3 and 4. Close to 700 patients. What they did was the standard arm was the regular treatments that we all get, cisplatin, high dose cisplatin, and radiation at 70K. What the experimental arm was, addition of avelumab in week 1, subsequently during chemotherapy and radiation, and 12 months maintenance. The primary endpoint was a PFS, and you had a host of secondary endpoints, overall survival or response rates of these particular patients. Again, at around 2 years, we find that the PFS was hovering around 50%, curves exactly overlapping over each other, hazards of 1.21. It's not significant. So we had one negative trial of attempt to study avelumab at a particular dose a week prior during concurrent chemoradiation therapy and maintenance, as compared to the standard cisplatin based high dose. chemotherapy in locally advanced HPV stages 3 and 4 positive as well as negative patients. The other study is the Keynote 412 study, and in this, again, it was unresected head neck cancers. The standard arm was again cisplatin, and of course, they had 2 doses of radiation therapy, the accelerated fraction and the standard fraction of radiation therapy. But here, the pembrolizumab was given concurrently along with chemotherapy and radiation therapy, and of course, the experimental arm had a maintenance dose of pembrolizumab for around 14 cycles. The primary endpoint was EFS, and the secondary endpoint was overall survival, safety, and quality of life. So the EFS at 36 months was, this curve seemed to separate 57%, 51%, hazards of 0.83, but again, the confidence intervals crossing unity, so not significant. In case of overall survival, the curves actually sort of, overlap with each other, no difference. So we had the Keynote 412. Again, this was, believe me, it was concurrent along with radiation therapy, the immunotherapy used, and they had a maintenance arm as well. The EFS was statistically, in terms of numbers, it was, there was about 5% difference, but it was not significant. Overall survival, not significant. Again, they tried to study by looking at an enriched population of a CPS more than 20. The numbers, again, theoretically, there seems to be some sort of a difference between the EFS and the overall survival, but again, not significant. So both the Javelin and the Keynote 412 pivotal trials used in concurrent settings were failed trials. You had one more trial, and this was the IMvoke012, in which they had a surgical arm as well as a non-surgical arm. So whatever the locally advanced head neck cancer patients, they underwent the standard treatment as mandated by the treating clinician. Subsequently, they were randomized to 16 doses of atezolizumab versus placebo. The endpoint was event-free survival. Again, both the EFS and the OS the curves seem to match each other, so no significant. So in summary, I just gave you 3 studies, but there are a host of other studies as well in the immunotherapy space of locally advanced head neck cancers. We discussed about the Javelin 100, the Keynote 412. There have been a lot of other smaller studies in the cisplatin ineligible cohort of patients as well, with various primary endpoints. All of these trials were negative trials. So what about neoadjuvant immunotherapy? And the rationale for giving neoadjuvant immunotherapy was to build an immune response to the tumor. They felt that in untreated patients with an intact tumor, you introduce the immunotherapy component at that time, the responses is slightly better. It is what is called as an immune reduction. They felt that could alter surgery. And these are basically hypotheses. So there was an interesting hypothesis of trying to reduce the adjuvant therapy. But again, this is something that is still more experimental. Even neoadjuvant immunotherapy itself as a concept, again, the guidelines don't really recommend it, but it's a promising concept which we need to sort of see and explore. So this is something that is much more like, they try to reduce the dose of RT and reduce the dose of CTRT, and this is especially in the HPV positive cohort of patients. Again, the mechanism of action, there is a 2 supposedly mechanistic aspects of this. You could have a pre-existing anti-tumor immunity which gets unleashed, as I said, in the naive setting, or there could be a direct cytotoxic effect as well. And what they say, especially in the immunotherapy concept, when the lymph nodes are intact, what is called as a functional lymph nodes, what it says that it provides a vaccination of sorts and this causes an enhanced durable immune response for patients. So it is believed that if you are introducing immunotherapy in a patient who has an intact tumor and with functional lymph node status, which are very, very important barriers of spread, the tumor antigen burden seems to be in place and you have an enhanced durable immune response. So these are some of the mechanisms or suggested mechanisms of actions of neoadjuvant immunotherapy. Again, there have been multiple studies, whether, again, as surgeons, we want to know whether giving immunotherapy is safe for patients prior to surgery. Multiple studies have suggested no impact in either the planned surgical dates, either the complications. Very few disease progressions may have happened, but it's very important that you choose your patient correctly for that particular studies. Again, there is a gamut of studies of neoadjuvant immunotherapy in head and neck cancers. A lot of them are phase 2 studies. Three of them have completed. A lot of them are ongoing, and they have studied responses of various cohorts. I'll just try to focus on one study, the Olivia et al. Study of pembrolizumab, 2 cycles, then surgery by week 5, subsequently cisplatin plus radiation therapy, and then subsequently you went on to sort of look into the endpoints, which is high risk pathology and PTR2. I'll come to this in the subsequent slides. So again, this was the non-randomized multi-center trial, 2 cohorts of patients, in which the first cohort they gave 1 dose of pembrolizumab prior to surgery. The second cohort, they gave 2 doses of pembrolizumab, very short, smaller cohort of patients. It was a non-randomized 2-group cohort of studies, and based on the pathology, they could escalate the treatment for some of the high-risk histologies. Again, the primary endpoint was 1-year recurrence rate of high-risk pathology and PTR2 status in all patients. And what is PTR2 is something that I will come to this slide. That is responses more than 50%. So what the study basically found out is that if you gave 2 doses of pembrolizumab prior to surgery, a greater number of patients had a more than 50% response. That is, they were downgraded to the PTR2 status, and that is the rationale for giving 2 doses of pembrolizumab prior to surgery. And this is also reflected in the same thing in the cohort 1 as compared to the cohort 2. You had a greater proportion of patients with the PTR2 status and a lesser number of high-risk patients also in the group that was given 2 doses of pembrolizumab. And that's the rationale for giving 2 doses of pembrolizumab in the study. That was the Keynote 689 that was published in the NEJM in June. Again, in this particular study, all newly diagnosed resectable head and neck cancer patients, and these are the surgeries who would have traditionally undergone upfront surgery. All the stage 3 and stage 4 patients across subsets, and a lot of them were oral cavity. I will come to that distribution in the subsequent slide. It had a generous distribution of P16 positive and negative patients. You did have tissue for PD-L1 testing, ECOG 0 1, 714 patients. The standard arm was what we all do, surgery followed by radiation therapy and cisplatin, and the experimental arm, as I discussed earlier, 2 cycles of pembrolizumab, surgery, followed by pembro with chemo and radiation therapy, and then 12 doses of pembrolizumab. And the primary endpoint was event-free survival. In a majority of the surgery of the cases in which they have used neoadjuvant immunotherapy patients in lung cancers or in any other cancers, the event-free survival and the pathological response rate seems to be either a single endpoint or a co-primary endpoint, with a host of secondary endpoints being the overall survival and obviously the safety profile for these patients. Again, as I said, this is important to note that a lot, 60% were oral cavity cancers. HPV positive rate was just around 3%. A lot of them were actually smokers and alcohol. So this is the classic cohort of patients that we see. Oral cavity patients, smoking, alcohol use, HPV status very less, and you did have the CPS, the PD-L1 status known. Majority of them were CPS more than 1. That is, more than 95% were CPS more than 1. So this is the classic cohort of patients that we all see and treat in the clinic, and we would all operate these particular patients. Again, when it came to the treatment disposition, intent to treat, again, what happened was that a lot of these patients had undergone surgery. So close to about 90% of the patients, 88% and 87% underwent actual surgery. So that means giving neoadjuvant pembrolizumab did not actually did not make the less patients come for surgery. Again, with the distribution of high risk, low risk was all same. But again, the one problem that I could actually see in this study was only around 70%, only 3/4 of these patients in both the pembro as well as the standard of care arm received radiation therapy. Normally, in locally advanced setting, you would have patients who receive radiation therapy adjuvant. And that is one problem that I could find in this particular study, where only 3/4 of the patients, both in the pembro arm as well as the standard of arm, only received radiation. That means a close to quarter of these patients actually ended up not receiving radiation therapy. In this arm, it was only surgery, and in this arm, obviously, there was a pembrolizumab and surgery for these patients. So that was the only major issue which I had with this particular trial. Again, when it came to the radiation doses, by and large, they were matched. Cisplatin, more than 200 milligrams per meter square, close to 90% of the patients in both the cohorts. And in terms of median duration of cycles, everything was matched between both the studies. Again, this was the impressive EFS endpoint, CPS more than 10 population. Again, at 36 months, you had a 14% advantage, 60% to 45.9%. A positive readout in terms of the EFS in the more than 10% population with a hazard ratio of 0.66. Again, in the CPS more than one population, you had a similar benefit, hazard of 0.70. And in the all cohort population, also, you had a similar magnitude of benefit with a hazard impressive ratio of 0.73. Now, if you see the particularly, this plot is very important to suggest which of the subgroup of patients actually benefited from this trial. The less than 65, male patient, white, oral cavity and oropharynx, they seem to benefit quite a lot. And surprisingly, hypopharynx patients, which we all feel that sometimes because these cancers tend to be biologically aggressive, but for some reason they didn't seem to benefit quite a lot. And of course, the smoker cohort of patients, the former and the current smokers, seem to benefit from this particular trial. These are the curves of the overall survival, and I have taken this from the NAGM publication. There seems to be a separation of curves at 3 years, 68% versus 59% in the CPS more than 10. Similar separation of curves in the CPS more than 1 and the total cohort of population. But again, the authors concluded that these interim results were premature and they needed more follow-up. But I believe that this study may have a benefit in overall survival. Of course, that is with the time to come. So the investigators concluded that addition of neoadjuvant and adjuvant pembrolizumab to the standard of care that we all practice in all cohorts of patients, more than 10, more than CPS, more than 1, and in all patients benefited. The overall survival was not statistically significant in the further follow-up, but again, I believe, as I said, that I feel that the benefit may be there, but of course, only time will tell. More importantly, for us, from the surgical perspective, the surgical complication rates were not changed, and fewer patients had higher post-operative benefit. That means addition of pembrolizumab might have downgraded some of the high-risk patients to a slightly lesser high-risk cohort of patients. Of course, this is something that unless we see the study cohort deeply, we will not be able to know. Again, no new safety signals. That's what the investigators said, and they claim that it is a new standard of care for patients of resectable locally advanced head cancers. Again, what worked for this? Again, as I said, like in the initial beginning, there was a host of studies in the concurrent and the adjuvant settings that failed. But what really worked for Keynote 689? Again, as I said, possibly because they used pembrolizumab priming of the immune system with 2 cycles. Surgical debulking actually happened in all these patients, close to 90%, favorable microenvironment to sort of bombard them with further adjuvant pembro and RP. Believe me that, the standard arm only consisted of surgery with radiation therapy. And this is something that we traditionally have been doing for the last 2 or more decades. But again, the experimental arm had a heavy dose of both pembro, preoperatively 2 doses, pembro along with radiation therapy and adjuvant pembrolizumab for around 12 months. And again, possibly the perioperative strategy probably seemed to work because of sustained immune response. And again, they had a biomarker-driven guidance. We know that PD-L1 CPS scores, although not a perfect biomarker, seems to suggest that it can be of some use for these patients. Again, this is a comparison of the 3 trials, the landmark trials that I said, Javelin 100, Keynote 412, and the Keynote 689, why these 2 failed, and the Keynote 689 seemed to meet the criteria, possibly because the safety was manageable, trial was a positive readout, and possibly there was a smarter timing of the use of the pembrolizumab and biomarker enriched population of these patients, and that's why possibly they could get a positive benefit in the EFS for some of these patients. Again, in ASCO 2025, we did have another study called the NEO post-op study, and this is the adjuvant study. Supposing we all say that we all want to practice a standard of care that is surgery plus post-operative radiation for these patients. Again, in some of the high-risk cohort, what was shown is you add nivolumab in the adjuvant and also add nivolumab in the maintenance setting. About 680 patients were given, and this is the standard therapy that we all give for these patients. Again, it was presented in the abstract form. It said the primary endpoint, of course, since it was given the adjuvant setting, is the disease-free survival. Of course, the key secondary endpoints are overall survival. This was a positive readout study as well. So in case people have some objections or some inhibitants to give the immune checkpoint inhibitors in the neoadjuvant setting, supposing in the high-risk adjuvant setting also there is a trial of a positive readout of nivolumab, that is in the NEO post-op study. Of course, we await formal publication. This is being published only in the abstract form, but at least it is an exciting time for all of us. Many other studies are actually happening, the JADE, the EVOLVE, and many other studies suggesting the use of novel agents, dostarlimab, and also, again, combination of these agents, PD-L1 plus the CTLA agents, with varying degrees of endpoints of EFS as well as primary performance. Again, it's important to know some of the safety endpoints, considerations for these patients. Unlike chemotherapy, which traditionally affects the mucous membranes, these immunotherapies tend to have specific toxicities pertaining to the skin, pertaining to the GI, dermatitis, rash, pruritus, colitis, diarrhea, and in advanced cases, you could have some degrees of toxicities of endocrine, hepatic, pulmonary, and renal. Again, it is important to know, especially from the people who are using it, the median time of starting of these therapies could be around 10 weeks time by the time you get this cutaneous and the GI toxicities, and possibly a little later or earlier than 10 weeks you could get the cutaneous and GI toxicities, whereas at 10 weeks or beyond you could have some of the endocrine, hepatic, pulmonary, and renal toxicity. And mind you, some of these toxicities can be crippling also for some of these patients. So that means it's very important that patients on immune checkpoint inhibitors are subjected to thorough clinical evaluation for immune-mediated side effects, CBC differentials, TFTs, because a lot of these patients could be either hypothyroid or hypothyroid. Even cortisol levels may be depressed for these. So all it is important that we work up of the patients who you are going to operate, especially after we have received immune checkpoint inhibitors. It is important for us to know, to evaluate for the immune-mediated adverse events, study the regular things. Obviously, CBC differentials we do study, but it's important to also study the levels of cortisol. Thyroid function profile also is mandatory for some of these patients, apart from your other metabolic profile for these patients. And there's a standard criteria to do these assessments, both the clinical, hematological, as well as the radiation-induced side effects, because you could get a lot of the immune-mediated pulmonary side effects as well as the GI side effects also. And of course, how to treat is something that is beyond the purview of this talk. To conclude, I think I could sort of take some questions if there is time, but again, I felt like, I should sort of highlight some of the buzz that has happened over the last few months. The standard of care for locally advanced head and neck cancer patients has not evolved, as I said, for many decades. Checkpoint inhibitors, majority of the trials were negative to date. And possibly it is poor patient selection, heterogeneous population, and no biomarker selection. But all these three factors seems to have worked in the Keynote 689 with a smarter patient selection, a more homogeneous population of patients. That is exactly the kind of patients that we sort of treat: oral cavity patients who are smokers, who are HPV negative, and who are heavy alcohol users. And these are the classic patients that we tend to treat, and better biomarker selection driven sort of patients. So you could get a positive readout, at least in the event-free survival for some of these patients. So again, it is important that there is a multidisciplinary care for these patients. Patient selection, as I said, is very, very important. It's the key. And again, you had two neoadjuvant trials and two trials, basically one in the neoadjuvant space, that is the Keynote 689, and one of the adjuvant space, and the Nevo post-op study showing positive. So again, it is a major potential impact in the metastatic disease is there, and now it seems to be moving towards the frontline therapy. As of now, some of these guidelines don't really sort of endorse the setting. Even the DCGI, the papers are there, so it's not yet approved for clinical use as such. But definitely, I think it is important as surgical oncologists who treat head and neck cancers, especially in the locally advanced space, to sort of understand where the field is going. And in I tried to sort of give you some information on the nuances of using neoadjuvant immunotherapy in some of these patients and also in the adjuvant space as well. I would stop my presentation here and would be happy to take any questions in this regard. Thank you again, Azim, Sunaina, for the opportunity.
Thank you, sir, for this wonderful talk for the emerging role of immunotherapy in the neoadjuvant setting. So are there any questions that anybody would like to ask?
Yes, I would like to ask a question. Can I? I'm Professor Manoj Sharma. I was working in the Cancer Institute earlier.
Yes,
And it's a bit of a question and bit of a comment. I have witnessed the bleomycin trial in head and neck cancers way back 30 years, 40 years back. And I tried to repeat it. Of course, bleomycin disappeared because of the notoriety of its total toxicity and so on and so forth after the arrival of cisplatinum. The problem we used to face with the bleomycin was that there was rapid cell regeneration, tumor regeneration. And because of that, hello? Hello,
yes, sir,
hello.
we can hear you, sir.
Yeah, because of this, a lot of things used to happen, and these cell regenerations could not be detected because those cases were immediately operated. Bleomycin happens to be a very strong and potential tumoricidal agent in our times. I was wondering if Dr. Arvind would like to conduct a trial, including bleomycin, with this immunotherapy.
Yeah, thank you, sir. Thank you for the comment. And it's important to note that, yeah, I think Dr. Shanta and Dr. Krishnamurthy were involved in the successful conduct of a trial with bleomycin. It was published in 1980s. But I guess, sir, from what I know is that agent seems to be effective, as you had also said, but I guess the side effect profile was something that is slightly unique for these patients. And possibly because of the availability of newer agents and better, I'm not sure whether they're really better. Maybe this platinum taxanes have been really better, and that's the reason why actually the interest in bleomycin seems to have faded over the years. But nonetheless, I think the trial that you were mentioning is mentioned in even the current NCCN 2025 guidelines of head neck also contains the role of bleomycin, and the trial is also quoted there as well, sir.
One more comment. Bleomycin was more blamed for pulmonary toxicities.
Yeah. That
right?
was the toxicity profile did not
but
seem
the
to.
point was that at Cancer Institute, there was a very strict scrutiny before the BLM used to be given.
Right.
So anyway, I wonder if you can try it again and make a new come out with something new.
You can explore it. Anyway, we are using it routinely in the testicular cancer patients management.
Yes.
So it's something that we are currently using it as well. But point taken, sir, it can be explored.
Head and neck cancers, yeah. And congratulations, wonderful presentation. I'm enlightened, old generation person. Although keep hearing a lot of things, leave time for others to ask the questions.
Thank you, sir. Appreciate it.
Thank you for the good question. So, Abhishek here.
कनेक्ट करो भाई, कैसे डिस्कनेक्ट कर दिया तुमने? क्या किया तुमने बीच में बेड़ा? डिस्कनेक्ट हो गई।
Can we move ahead to the next session?
Yeah, I think I'm good. There are a couple of questions in the chat. If you can, if the panel
Okay,
can
yes.
take it, or should be okay.
So yes, sir, you can take the questions.
It's an interesting comment on the role of tissue plasticity in immunotherapy. I think that's about the pathway and how the resistance mechanism seems to happen essentially. So I guess a lot of this thing is in evolution, and as rightly said, like not at least in the metastatic space, we know that these agents don't work for a lot of these patients. Only about 20% seem to benefit. We don't know why many others don't really sort of have an immune escape mechanism of this. And maybe plasticity or tumor heterogeneity with the EMT pathway seems to sort of play a role in it as well. So I think it's exciting times ahead, but the problem is we don't really know how to sort of which is the perfect biomarker in a way to sort of use. There have been many other biomarkers, better biomarkers than PDL1 that's been trying to sort of see, but then I guess a lot of them are not currently in practice. And again, it's a problem as to how to manage some of these patients once they progress of immunotherapy. Also, that's also a big challenge for us. Caleb has asked, would you change your practice or wait for more long-term data? Yeah, I think, of course, first, purely from the technical perspective, we are awaiting some of the approvals from the DCGI, and I'm sure that they would formally approve it. Yeah, you're right that it's exciting. I feel it's a practice-changing trial. Because in lung cancers, we have actually changed practices. We are now incorporating immunotherapy, especially in the driver-negative patients, of resectable cohort of patients. Again, as I said, Caleb, in the forest plot that we suggested, younger than 65 years of patients, oral cavity, T3 patients, smokers, all these, some of the high-risk patients. Although I would have sort of, actually wanted to sort of give it in the cohort of say hypopharyngeal cancers, which we traditionally believe to be aggressive cancers, but surprisingly this trial in that particular cohort of patients did not show much of a benefit. So, but again, it's very difficult or not correct to actually go into this unplanned subset based analysis. But again, in the real world, if you have to make a choice for some of these patients, younger patients who have been using tobacco and who are sort of oral cavity, these some of these cancers seems to sort of benefit at least from the cohort of patients that have been shown in the particular trial. Yeah. Rahul, bispecific antibodies. Again, there is a lot of buzz going on in this. As I said, they're trying to sort of combine two immunos also, some with bispecific antibodies also, but again they are sort of work in progress. Again, we will actually have to wait for good real world evidence on this, and at least I'm happy to say that at least in this space we have got 2 positive readout trials and more to come, hopefully. I'll stop at that. Any other questions I would take, or otherwise get over back to them.
If there are no more questions, can we move ahead?
Last question. Arvind, last question. Would your radiotherapy colleagues would like to sort of make similar trial where the cases cannot be operated or they are misfit for the surgery?
Yeah, as I said, sir, that the positive readout has come only in the resectable cohort of patients. Unfortunately, the use of the immunotherapy in the adjuvant space, in the concurrent space, especially, they don't seem to have made a big dent. So we will wait again because of the positive readout for this trial. I'm sure the buzz is there. They may try to sort of use these agents in a different setting altogether. So we'll have to wait for more data, but in this current time, given the evidences, I guess for the unresectable patients, we may have to wait. We will just go with the traditional treatments and possibly reserve immunotherapy uh, in uh, in in the metastatic setting, or as I said, like in the recurrent or metastatic setting, we will reserve it as for now. Thank you, sir. I think over to you also. You can just start. I think just over short time.
ठीक है स्टार्ट करने वाले हैं अगर
जी
अभी कुछ मत करो ना कुछ मेरा फील पड़ रहा है
कुछ दिस check
म्यूट Okay. So today, I would like to welcome Dr. Abhishek Vaidya, sir. He is a senior consultant in head and neck surgical oncology, National Cancer Institute, Nagpur. And Dr. Smriti Panda, she is an assistant professor in the Department of Head and Neck Surgical Oncology, AIMS, New Delhi. And Dr. Shwetab Sinha, he is an associate professor in the Department of Radiation Oncology, TMH, Mumbai. And today's case presentation will be done by Dr. Surjalata. She is a MCH resident from AIMS, New Delhi.
Okay, hello everyone and thank you. So, ready whenever you are, Dr. Sujalata.
Yes, sir.
Please
Ma'am,
begin.
ma'am, my screen is visible, ma'am.
Yes, it's visible. Can you make it full screen, please?
Yes, ma'am. Good evening, everyone. Ma'am, should I start about presentation?
Yes, you can start.
Okay. Today I'm going to present about one case, locally advanced oral cancer. About CHIP complaint. My patient is 53-year-old male, resident of Jhansi, UP. Occupation work as an engineer. He presented to OPD with the CHIP complaints of non-healing ulcer over the right side oral cavity for the last 6 months and a decreased mouth opening for the last 1 month. About the history of present illness, the patient was apparently all right 6 months back when he noticed an ulcer in the right buccal mucosa for the last 6 months, which was insidious in onset, gradually progressive in nature. Initially, it was approximately size of a peanut, but gradually increasing the size, reaching the present size for the last 6 months. It was associated with the foul smelling. It was associated with pain localized to the site of the ulcer, non-radiating, not refer to other sites, mild to moderate, which is aggravated on chewing food and gets relief with painkillers. Associated with decreased mouth opening for the last 1 month, which is gradually progressive. And it was also associated with the swelling over the right side neck for the last 3 months, which was insidious in onset, gradually progressive in nature. Initially size of almond, but gradually increased the size for the last 1 month, but it was not associated with pain. He also had the history of loosening of the tooth, right, lower second molar for the last 1 month, and the history of the tooth extraction before the onset of the disease. No history of oral bleeding, sharp teeth, no history of numbness over lip, chin, no history of cough, hemoptysis and respiratory difficulty, no history of any bony pain, abdominal pain, no history of significant weight loss, fever, and any difficulty in swallowing food, voice sense, and any history of hematemesis, melena, jaundice. In the past history, he doesn't have any comorbidity like diabetes, hypertension.
Tulsalada, what's the significance of history over numbness over the chin? Did you ask that? I mean, you asked that. So what does that mean?
Sir, in the history, I asked the patient about the any history of numbness over lip chin area. It indicates, sir, the tumor may extend to the paramandibular, reaching the mandibular nerve, mandibular foramen. So, if the tumor involved that patient may complain about the numbness in the lip and chin area, sir.
Okay, go on.
Yes, sir. He doesn't have any comorbidity like diabetes, hypertension, COPD, asthma, any cardiac, renal illness, thyroid disease, tuberculosis, and no history of any previous cancer, and no history of surgery in the past, no history of any non-drug allergy. Yes, sir. On addition history, he had the history of the tobacco consumption in the form of the chewable tobacco, gutka, approximately 2 to 3 times a day for the last 10 years and quit 4 months back. And he also had of the back history of alcohol intake occasionally for the last 10 years, but not able to quantifiable. General examination, patient is conscious, cooperative, well
So
oriented.
from the history, why do you think he has trismus? Because you said that the trismus is of only 1 month's duration.
Sir, from the history, like he had the disease was progressing for the last 1 2 months, so might be because of the disease progression, pain, or maybe the tumor extension involving the like.
Was his mouth opening normal before? Did you ask that?
Yes, sir. I asked that he able to open the mouth properly, but it become started decreasing mouth opening for the last 1 2 months. Sir.
Okay.
Yes, sir.
Go on.
About the general examination, he's conscious, cooperative, well-oriented, and the ECOG performance 0, moderate will, well-nourished, weight is 80 kg, 162 centimeter, BMI 30 kg per meter square. His pulse rate is 78 beats per minute, and the BP 140 by 83. In the taken supine position, no pallor, icterus, clubbing, cyanosis, generalized lymphadenopathy, edema. About the systemic examination, CVS, the heart sounds are normal, no murmur, and the respiratory system also bilateral, breath sound normal, no added sound, abdominal and the CNS cranial examinations are normal. This is the clinical picture of for the patient.
Okay, so not related to your case in particular, but tell me why anemia is important in head and neck cancers.
Sir, anemia in head and neck cancer, if patient have pallor clinically, if patient may have the history of this bleeding from the tumor site, and one of the reason for that, and another reason is the sir, like anemia may in the impaired pre-anesthetic workup also we have to optimize the hemogram before the surgery, sir.
Okay, is nutritional deficiency related to worse outcomes?
Yes, nutritional status like patient will status that is more important for the cancer patient, sir.
Once again, not related to your case, but tell me 2 conditions which are associated with anemia and head and neck cancers.
Sir, patient suppose having the hematemesis or hemoptysis cases, that means the patient may have the anemia. So that means the patient have some distant metastasis sign and symptoms.
Okay, so the answer which examiners are usually looking at this point is Plummer-Vinson and Fanconi's anemia. Go on, move on to your case, please.
Yes, sir. Yes, okay. So on local examination, on inspection, mouth openings more than 2 finger breadth, inter-incisor distance 30 mm, grade 2 trismus, and he had the poor oral hygiene, tobacco staining on teeth with right lower first molar missing tooth and halitosis present. On the examination, found 4 into 2.5 centimeter ulceroproliferative growth present in the right buccal mucosa with extension anteriorly till the from the angle of mouth around 2.5 centimeter away, posteriorly reaching till just RMT, and the medially lingual surface of the lingual surface was free, floor of mouth, tongue are free. Laterally, growth spread along the zygovical sulcus till the right lower second molar anterior early, and overlying skin over right side appeared normal, pinchable, and superiorly around 1.5 centimeter away from the upper GVS. Other subsides of the oral cavity, tongue protrusion, mobility are normal, and the other parts of the oral cavity, floor of mouth, as hard palate, soft palate, oropharynx examination within normal limits.
Lata, on your examination of the face, there is some fullness which is visible on inspection, located around the buccal space, right? Even though your skin is free.
Yes, ma'am. On fullness, but patient on the ma'am in neck examination, he had the swelling in the level 1B, but the patient having some fullness, but the overlying skin is normal, pinchable, and no changes in the skin, no pudiorange changes in the skin, ma'am.
Is there any subdermal edema present? Do you feel that the fullness is extending up to the zygoma?
Ma'am, there is not fullness is not reaching till the zygoma, ma'am. It's mainly lower part of the cheek.
Okay.
On palpation, this is the tumor area bleeds on thus inspectory findings are confirmed about the extent of the lesion, tenderness present, and the right lower alveolar second molar tooth was missing, and the paramandibular spread present, and no loss of sensation over lip chin area, skin over the right cheek is pinchable. Rest part of the oral cavity normal. On the fiber optic transnasal endoscopy examination, oropharynx, larynx, hypopharynx and normal. Upper GI endoscopy also normal.
What is the importance of upper GI or flexible nasopharyngeal laryngoscopy in such cases?
Sir, in this oral cavity cases, we have to rule out the other possible second primary tumors.
Synchronous primary. What is the incidence of
Yes, sir, yes.
synchronous head and neck primaries?
Sir, synchronous head and neck primary incidence is range about sir 3 to 10%, sir.
Okay, you need to read that up. Go on.
Yes, sir. About the neck examination on inspection, no visible scar, sinus, fistula seen over the neck. Right level 1B, I found around 3 to 3 centimeter palpable lymph node, which is firm, non-tender, but overlying skin pinchable, but the node was fixed to the underlying structure, is immobile, and no other palpable lymph node elsewhere in the neck, and trachea is in central position.
So once again, going back to the question that was asked before, the cheek skin, is it pinchable?
Yes, sir. Cheek skin is pinchable, sir.
So that fullness which is seen there, is that edema?
Sir, fullness is the edema, but the overlying skin is pinchable, sir.
Okay. All right. And when you say the node is fixed to the underlying structure, what do you mean?
Sir, node is fixed to the underlying structure is clinically suspect the extranodal extension, sir.
Okay. What underlying structure are you talking about here?
Sir, in this underlying structure is the one of the lower border of the mandible. And another of is the like maybe the submandibular gland also, and underlying muscles like posterior belly of the digastric.
So did you mention about paramandibular disease?
Yes, sir. I mentioned on the palpation, the paramandibular spread.
Okay, go
Yes,
on.
yes, sir.
Lata, if I may ask, like at this stage, will you be able to say whether there is clinical involvement of the bone?
Ma'am, from the clinical examination about my case, since the patient had the history of the uh, loose tooth, and that is also, and the loose tooth, so tumor might be cross or extend over the occlusion surface of the lower alveolus. So I want to state as that clinically T4A, ma'am.
Apart from loosening of teeth, there can be other reasons for loosening of teeth. It need not be related to the malignancy. Apart from that, are there what are the clinical indicators to underlying mandibular involvement?
Another is the ma'am patient having underlying is the patient have unproportionately pain. That might be the involvement of the nerves in the lingual nerve or the mental foramen nerves. So that might also involve the bone marrow in the lower alveolus. That is the one of the criteria for the T4A. And another is the skin nodule present and non-pinchable skin present. That is the another point for the clinically T4A.
What you said, none of these are present, right?
Instead of that,
Pardon, ma'am?
sorry,
But
what I wanted to say was you did not mention that there was any soft tissue on the lingual aspect. So if you see growth on either side of the both the buccal aspect as well as the lingual aspect, so that is another clinical
Yes,
indicator
ma'am.
that
Yes,
maybe
ma'am.
your
Oh, okay,
yeah.
ma'am. Tumor involved in the both side means that it grows the after erosion the bone it extends. So one of the clinical criteria for T4A.
okay, go on. Examination of the neck.
Yes, sir.
Okay. So, what do you want to do next?
Sir, from the I want to give one summary for my case. He's 53-year male, history of the non-healing ulcer right here for the last 6 months. He's non-case of the addiction history, tobacco share with the occasionally alcohol, no comorbidity with the ulcerative growth in the right buccal mucosa with the fixed immobile node in the right level 1B. Now, next step, I want to confirm with doing the histology biopsy. I want to undergo biopsy for this case, sir.
What kind of biopsy will this be?
Sir, for this case, I will undergo incision biopsy, sir. Wet incision biopsy.
Okay. Would you be happy taking just an FNAC from that node?
Sir, we growth is clinically visualized like this is the one of the frank growth looking the carcinoma, squamous cell carcinoma, and the patient all this having the clinical features having not, so most probably I feel like metastasis, so I don't feel like doing the FNAC in this such kind of cases.
No, that's not the right answer, but the primary here is well accessible and easily biopsiable. So you'll do a biopsy from this.
Yes, sir.
Okay. What else do you want to do? So that one is biopsy. What else?
Sir, biopsy, and I want to do the imaging, cross-sectional imaging. Next steps there for this case, contrast enhanced computed tomography, face, neck, chest, to know the.
Okay.
Yes, sir.
So before your clinical, before your CT, based on a clinical examination, can you briefly stage the patient?
Yes, sir. From clinical examination, I will stage the. I can stage the patient, sir.
Yes, tell us.
This the carcinoma right buccal mucosa, clinically T4A and 3B MX.
So tell me your reasons for calling each of these T, N, and M categories.
Pardon, sir? P.
Tell me the reason for calling it T4A, N3B, M. Whatever you're saying, T, N, and M. Tell me the reason how you stage it like
Sir,
this.
in my case, I am calling T4A. Patient had the missing tooth, loose tooth, and the growth is paramandibular spread. So
Okay.
I feel like this is the one of the T4A
So,
involving the bone.
right. T4A on account of bone involvement. N3B on
Yes.
account of?
And 3B is the node is hard fixed to the underlying structure. So clinically, this is one of the definition for the clinically external.
Right.
Yes.
So clinical suspicion of extranodal extension. How
Yes.
about your M staging?
So M staging clinically, from the history and all, he doesn't have any sign and symptoms suggestive of the distant metastasis, but I could not able to sure. I'm not able to sure about the metastasis like subcentimetric metastasis to the most common site, lungs, and also I am for now I am giving the MX test.
Dr. Surjalada, what is the latest AJCC staging?
Sir, latest staging, they mentioned that is the no term for the MX.
Absolutely. So if you know that, then why did you mention that?
Sorry, sir, it's a mistake. It should be the M0. That is the not term in MX in the latest
Yes,
staging.
this is an important change which came in AJCC 8
Yes.
and has been continued, that you should not calling it MX. If you do not conclusively prove that it is metastatic, you should call it M0.
Yes, sir.
Go on.
Sir, after biopsy, it comes the well-differentiated squamous cell carcinoma. So next step, I want to undergo the cross-sectional imaging, contrast-enhanced computed tomography, face, neck, and chest in this case, sir, and routine blood investigations. And
Lata, do you routinely perform the biopsy before you imaging?
ma'am, routinely, like in advanced tests or in cases like in my cases is very frank growth is there. So if I perform biopsy first, the imaging, it doesn't not much hamper to the uh, over after biopsy inflammation. But in case of the early cases like T1, T2, buccal mucosa, and the tongue cases, that I prefer the imaging first before biopsy, because after biopsy, because of the inflammation, tissue may overestimate the size of the lesion.
Yeah, but it's generally better if you mention the imaging first.
Yes, ma'am.
Would you be justified in asking for an MRI in this patient?
Sir, MRI for this case, if I want to know the like perineural spread condition, I will consider. And
No, just for specifically for this case, based on your clinical finding, you have only one investigation to do. Would you do a CECT or an MRI?
sir, for this case, I will prefer the CCT, sir.
And the reason being?
Sir, I want to know the bony condition and extent of the tumor. Bony erosion like cortex, bone erosion is more preferred in the CCT. Over MRIs is overestimate the cortex erosion of the bone. But if I want to know the bone marrow involvement and the perineural spread, I'll prefer the MRIs.
And why not a PET CT scan?
Pardon, sir?
Why not a PET CT scan? Dr. Abhishek is asking, why not a PET CT scan?
Sir, PET CT, according to the NCCN guideline, sir, PET CT is in case of the advanced stage, the 334 with heavy nodal burden and the lower neck node positive and multiple stage neck node present, PET CT preferred. But in our cases, like we are doing face, neck, chest, and including the chest also. So it will we will come able to know the metastasis and just in the lungs.
Okay, so yeah, so I would agree with your answer. The answer I would more like you to give is that the most common metastasis in head and neck are in lungs or
Yes.
in bones, especially vertebrae, and both of these would be screened in this. But yes, PET-CT can be done because this would be a stage. Give me, what stage is this clinically?
Yes, sir.
Stage grouping. What stage grouping is this?
Stage 4B, sir.
Correct. So a PET-CT is justified here, right? But I
Justified
would,
in this case.
but yeah, I'm perfectly okay with your investigation of choice as well. Yeah, as long as you're able to justify it.
Yes, sir.
Dr.
Okay.
Abhishek, I think you have spoken my mind because in Indian patients, see the primary size of tumor itself is very big. And
Right.
youngsters are generally misguided by the NCCN guidelines.
Absolutely.
And they have to learn that they have to set their own guidelines depending upon the follow-up based exercise. And because the people are smokers also, PET CTs are for surprise in Indian patients. So if the facility is available, the finances are available, I think one must go. You will be there for wonders.
Yeah. So if possible, this certainly is a case where you can do a PET-CT scan. I take your answer, but you have to justify that, right?
Yes, sir.
Okay. Your point is very well noted, sir. Thank you. Go on, Dr. Sujlata.
Yes, sir. This is my CT scan finding, contrast that's computed tomography finding. I found a heterogeneous enhancing lesion around size 4.2 into 2.7 into 1.2 centimeter in right buccal mucosa with the irregular margin showing the involving in the right side buccal mucosa and posteriorly abutting to the retromolar triangle area and loss of fat plane with the masseter muscle. And this is the axial view, and this is the showing in the coronal view. This is the tumor thickness around 1.2 centimeter in my case.
So Lata, because the bulk of your tumor is located near the retromolar trigone, so
Yes.
is there any particular cut that will actually give a better panoramic view of the RMT?
Multi-detector computed tomography fat suppression.
No. You have shown the sagittal, axial, and the coronal. So,
Yes.
is there any reformatted image where you can very nicely see the retromolar trigone and also the inferior alveolar canal?
Inferior alveolar canal, ma'am, is well visualized in the sagittal view, ma'am.
Anything, any modification of the sagittal which is done as a recon?
Uh,
Are you aware of the
ob-
oblique recon?
Oblique, yes, oblique recon. Yes, sir. I I read that about that.
Okay. Right. So as a surgeon, tell me what are you looking for when you see a CT scan of a locally advanced oral cancer? Tell me.
Uh, Cities from the CT scan, we want to see at the first is the tumor side a subside of the oral cavity lesion, and the size of the tumor, extent of the tumor, and relation to the relation to the surrounding structure like muscle, bone, and the bone erosion. Yes, and for this primary these things I want to know, but in the neck I want to see the level of the lymph node involvement, and it's about the shape of the lymph node, and maintenance of the perihilar lymph node, and it says any suspicious lesion in the mediastinum and the lung.
Right. So that is all general. We'll come to more specific points later. But now that you have the findings of the CT scan, do you want to restage your patient?
Yes, sir. From the CT scan, I want to restage for my case to T4B, sir, because of the loss of the fat plan with the masticator space masseter muscle, sir.
Okay. And what is the status of the medial and the lateral pterygoid muscles? Do you have any other cuts?
Sorry, sir. I have this cut only, sir.
Okay. What pterygoid muscle can be seen in your axial cut?
Medial pterygoid, sir. This is the masseter, and this is the medial pterygoid, sir.
Good. Okay. So is there involvement of the medial pterygoid?
Sir, not reaching the medial pterygoid is mainly involved the masseter muscles.
Yeah. So your staging would be T4B
Yes, sir.
on account of involvement of the masseter, which
Yes,
is a part of the
masticator space.
masticator space. Right. And how about your nodal staging on CT scan?
This is the nodal staging. Nodal on the this is on the Excel view. I found around this size of the node and 3 to 3.2 centimeter in the right label 1B. This is the loss of the fat plane between the overlying platysma muscle and underlying soft tissue muscle. And in this coronal view, I found this adherent to the lower border of the mandible.
So stage your neck now.
Sir, N3V, sir.
Are there any other nodes on the CT scan?
No, sir. Only this is only not, sir.
And the remnant of your CT scan, did that show anything remarkable?
No, sir. Only that this node is able. Baki no other neck nodes visualized in other levels of the node, and the CT chest also normal, sir.
Okay. So your final staging is T4B, N3B, M0, right? Clinical radiological staging.
Yes, sir.
What do you want to do for this patient?
Sir, for this patient, I want to first in the tumor board discussion about the staging of the tumor, and then I want to undergo the curative intent treatment, multimodality treatment, upfront surgery, followed by the adjuvant RT plus minus CT, sir.
Okay. Are there any other, sequencing that you're aware of for this? Yes, you're right. Curative intent, multimodality. Most often, and certainly in India, we would do an upfront surgery for this. Are you aware of any other sequencing of management for such patients?
Sir, in the latest 2023 Bernita Dorona mem paper, there when they discuss about that paper, they compared the resectable infranodes advanced stage disease with the T4A. There's the survival outcome become similar, sir.
So surgery, you're saying, right?
Yes, sir.
Okay. What would be your indications of considering neoadjuvant chemotherapy in locally advanced oral cancers?
Sir, in locally advanced, it's when I
Firstly,
by
would you
the
consider
borderline.
neoadjuvant therapy at all in locally advanced oral cancers?
Sir, when we divide borderline resectable cases in terms of when the case is borderline resectable cases, some according to the Patel and all, they give the some indications for the neoadjuvant chemotherapy. One is the extensive tumor edema.
What do you mean by borderline resectable?
Sir, borderline.
Since you said that, so I'm asking, since you uttered that, what is borderline resectable?
Sir, borderline resectable when the tumor involved the supranodes, like intermediate compartment, like example involving the lateral pterygoid, temporalis muscle. So, and when some conditions are like the patient having extensive tumor edema, reaching the like zygoma level in case of the.
Okay. So without getting into specifics, and okay, we'll come to all the specifics later, but tell me what do you understand by borderline resectable?
Sir, borderline resectable means we have to the when balance between the curative surgery and the functional and cosmetic defect. This should be more hampered.
Okay, that's a good answer. That's one part of the answer. that borderline resectable is when the functional impairment is likely to be too much, but you're still likely to get an R0. And the other part of this would be technically difficult R0, when R0 is not assured, right? When you're not sure whether you will be able to get R0. It is not downright unresectable, but sometimes there may be technical where R0, and it's not a well-defined term, borderline resectable, but broadly you can answer it in two senses. One of them you already said,
Yes,
that
sir.
where the functional impairment is likely to be too much despite having an R0 resection.
Yes,
And
sir.
the second would be when your R0 itself is doubtful, technically doubtful. Now,
Yeah.
So on that note, tell me the criteria of unresectability in oral cancers.
Sir, according to the Patel and all, they give the 5 criterias. One of the is the extensive tumor edema, skin edema, reaching the zygomatic level.
Unresectability.
Unresectability, sir. Unresectability when the tumor involves the height sopranos disease like involving pterygomaxillary fissure and the intracranial.
Unresectability, absolute non-controversial criteria of unresectability. Come on.
Sir, tumor reaching the pterygomaxillary fissure and intracranial unresectable, sir. Sorry, tumor involving the encasing the carotid artery, involving the prevertebral fascia. These are the conditions for the unresectability, sir.
Correct so far. So, tumor or nodal disease involving the prevertebral fascia or encasing the carotid artery or involving the carotid arteries. Anything more? Come on, for oral cancers.
So,
extensive skull base involvement.
yes, sir. Okay.
Right?
Yes, sir.
Okay. Now go on to the specifics of what you said was technically borderline resectable. Go on.
Sir, technically borderline resectability, they give the some conditions like the in case of the buccal mucosa cases involving tumor edema reaching the zygoma, and in tongue cases the anterior two-third tongue lesion reaching the bellicula and the level of the hyoid, and extensive skin involvement, and there's the height sopranos disease reaching the pterygomaxillary fissure. Yes.
And now explain why each of these is considered as technically borderline resectable. You may give your own reasons because there are no strictly specified reasons, but for each of these, which you said, give me your reasons. And one more which you missed is nodal disease reaching hyoid.
Yes, sir.
Yeah. So this is as per the VM Patel paper. But tell me, why do you think, have you ever questioned why all of these are considered as borderline resectable? Tell me, according to you, why are these borderline unresectable, technically borderline unresectable?
Sir, when the tumor reaches the height sopranos disease like pterygomaxillary fissure, that is the difficult to get the R0 resection because the distance from the skull base to the pterygomaxillary fissure, it's the around 3 centimeters, sir. And to the to the mandibular nodes is distance is the 2 centimeters. So there is difficult to get a deep margin in that cases, sir, to clear the disease.
Lata,
So,
pterygomaxillary fissure is much higher up.
yeah.
Okay, so the distance what you are saying is from the inferior border of the pterygoid plate. It's not from the pterygomaxillary fissure.
Sorry, pterygoid plate. Yes, from the skull base, one is the nodes and the pterygoid plate. Yes.
Yeah, so the reason for pterygomaxillary fissure would be very difficult to get medial and superior margins.
Medial
Okay,
and
superior margin would be at the infraorbital fissure. You cannot go there. Medial margin would also be difficult. Okay, go on. Next point.
And the second point, when the in case of the tongue, when the anterior two-third tongue lesion reaching to the zygoma, so we have to undergo the extensive surgery like total grossectomy and oropharyngectomy, that makes more morbidity to the patients.
Okay, so tongue lesions reaching the vallicula would require you to take margin at the supraglottis that crosses a compartment of head and neck, and that makes the surgery extremely morbid. Right. Next point.
Next point, when the patient having the tumor edema reaching the zygoma, so that we may need the both extensive skin excision and difficult to get the R0 margins.
Right. So large skin involvement, especially above the zygoma, not only makes resection and reconstruction slightly more difficult, but it also introduces new nodal basins such as the parotid and has a chance to produce cutaneous nodules. That's
Yes.
correct. Now, fourth point, hyoid.
Sir, when the tumor or nodule reaching to the level of the hyoid, when to get the inferior margin, we have to remove the supraglottic part of the supraglottic, sir. That will impair.
Good. Once again, transgression into another compartment and likely involvement of the preepiglottic space. Okay, good. Move on.
Lata, sorry, one more question. So sir was mentioning about certain unconventional nodal basins. So when you have a primary located in this particular location, so apart from the Robbins levels that you know of, what are the other lymph nodal basins that have recently been discussed in literature?
Nodal events, ma'am, from the east subside or from this buccal?
From the gingival-buccal complex.
From the gingival-buccal complex, most common subside metastasis is the level 1B, then 2, 3.
Yeah, that you have already mentioned. Do you know anything about the perimarginal group of nodes?
Yes, ma'am. Patient from that tumor metastasis may go to the near the perimarginal lymph nodes, like margin near the around the marginal mandibular nerve.
So where is it located? Is it located below the mandible or is it more upstream?
More upstream, ma'am.
Yeah, it's typically located above the mandible, so between the mandible and the alveolar process.
Yes.
Okay, so this is something which is not conventionally addressed during a routine neck dissection. And in the presence of extensive skin involvement and a higher nodal burden, like in your patient, you
Yes,
can have occult metastasis in that particular quadrangle.
yes, ma'am.
Yeah, please carry on.
So, what is your plan for this patient?
Sir, plan for this patient about the multimodal treatment, surgery followed by adjuvant plus RT plus minus CT. And plan surgery is the white local excision. I want to undergo the right segmented mandibulectomy, right MND, and low ITF clearance, reconstruction with the free fibular flap if available. Another option for reconstruction, consider resonant with Mpmmcc flap.
Okay, before I go into the specifics of your surgery, please tell me whether my next sentence is true or false. For resectable locally advanced oral cancers, surgery is the first line of treatment and neoadjuvant chemotherapy must not be given.
Sir, resectable oral cavity.
Locally advanced oral cancers.
Cancer, if the resectable is the surgery, upfront surgery is the better, sir.
Tell me evidence which bears this. You're right.
Yeah.
For resectable oral cancers, even locally advanced, neoadjuvant chemotherapy has no role. Is there any evidence to support this? You're right, but give me the evidence.
Sir, neoadjuvant, we can advise when the
No. I'm saying no role of neoadjuvant in resectable oral cancers. Tell me the evidence which supports this.
Sorry. So exactly, I don't remember the paper exactly, but
Do you know the mandibular preservation trials, Lata?
mandible preservation trial, ma'am, that is the Licitra and all. They consider the when the patient doesn't have the any bone erosion, bone erosion, when patient having only the paramandibular spread, when we want to consider the mandible preserve, the according to the Licitra and all, they consider the NACT 2 or 3 cycle with the then followed by response assessment. If the in their paper they are preserve around 21% of the mandible, but they don't have any the overall survival improvement.
Yeah, so no survival improvement. Also, your percentage of mandibles which could be preserved is incorrect. So you need to read that again. Another trial which did not show any survival benefit, randomized control trial.
Sir, Choker and all paper,
Zhong et al.
Fan Jong also.
Okay, now moving on to your surgical plan. In your CT scan, did you tell us what is the extent of bone erosion?
Sir, on the CT scan, bone erosion is I found in the this missing tooth area. One of the area patient having this is a soft tissue deficient of the bony structure and the soft tissue enhancement in the this area. So this is the bone erosion area, sir.
Okay, craniocaudal, how much is it? What is the depth of erosion into the mandible? What is the remnant mandibular involvement? Is there mandibular canal involvement? Is there marrow involvement? What is the anterior and posterior extent of the bone erosion? Are any of these important for your planning resection?
Yes, sir. If we want to know the this one minimum, if we want to know the if patient has only the outer superficial cortex, if we are planning for the marginal mandibulectomy, minimum 1 centimeter lower centimeter of the mandible to be preserved. So in our case, sir, is the bone marrow tumors extend till the bone marrow. So I want to do segmented mandibulectomy.
Okay, so you know that the medullary cavity is involved, correct?
Yes.
Is there involvement of the nerve canal? Is that important?
Yes, sir. For perineural spread. For that, if we want to know details, I didn't do the MRI, sir.
Okay, so once again, let me reframe that question. How will your management change if you think that there is involvement of the inferior alveolar nerve canal? If even on CT there is bone erosion deep enough to cause nerve canal, or there is nerve canal widening, let's say there is nerve canal widening on CT scan.
Sir, on the imaging, when we suspect the perineural spread, so at the time of the surgery, we have to sacrifice the nerve till the foramen oval, sir.
Okay, so that's correct. Point two, number one is if there is nerve canal widening on CT scan, you ask for an MRI to look for perineural extent at the exit foramen, correct? At the lingula, the exit foramen, the lingula. And then you have to resect the entire canal, entire length of canal within the bone,
Yes,
correct? And obtain free margins on the nerve,
yes, sir.
right? So in this case, since you're planning a segmental, I assume that you're not removing the entire length of the canal. And therefore, I assume that you have confirmed that the inferior alveolar canal is not involved. Is that correct?
Sir, in my case, sir, segmental mandibulotomy I will do, and low ITF clearance also I will do, sir. So it will.
So, what segment of the mandible are you resecting?
Sir, segment is the posterior segment starting anterior cut from the level of the canine level, and posterior segment is the in the subcondylar, sir.
Subcondylar. So, you will preserve the condyle
Yes, sir.
while removing the remnant mandible. Is that correct?
Yes, sir. Coronoid Coronoid I will remove, and the subcondylar posterior I give.
And you will take a subcondylar cut. Understood. Right. And you are planning a low ITF resection, you said. What does that mean?
Sir, because in these cases the tumor is the loss of fat plan with the masseter muscle, means the low ITF involvement. So I want this masseter muscle and medial pterygoid as a deep margin will be included to the specimen, sir.
Good. So an oblong resection of the medial pterygoid, entire medial pterygoid,
Yes, sir.
cutting it at its origin.
Yes, sir.
Okay. So whenever you say segmental, it is preferable you mention which segment. Okay.
Yes, sir.
Because a segmental may just include the horizontal, right?
Yes, sir.
Okay, so LCH, so you should always mention which segment.
Yes, sir.
Okay. What do you understand by compartmental resections?
Sir, compartmental resection in the oral cavity in buccal mucosa cases like involvement when we clear radical resection the ITF fossa and infratemporal fossa together, all the muscles and the soft tissue neurovascular structures together, sir, to get the clear deep margins, sir, deep soft tissue margins.
So what compartment are you resecting?
Infratemporal fossa, sir.
Or the entire masticator space?
Yes, sir.
Correct, the entire masticator space.
Entire masticator space.
Yeah. Quickly, can you tell the difference between the masticator space and the infratemporal fossa? Quick.
Sir, masticator space and the infratemporal was this radiologically they use the different time. Masticator space is the space from the investing layer of the deep cervical fascias, and the infratemporal fossa, this is the only soft tissue space, and the in masticator space it involved the component medial pterygoid ramus of the mandible masseter, and
Yeah, so ramus of the mandible and masseter are two things which are included in the masticator space, but not in the infratemporal fossa, right?
yes, sir.
So for compartmental resection, you are doing an entire masticator space resection.
Yes, sir.
Okay. Now, let's say your patient had disease in the retromolar trigone, in the upper gingival sulcus, eroding the upper alveolus, and on CT scan, there was erosion of the entire ascending ramus of the mandible, almost up to the coronoid, and there was involvement of the insertion of temporalis fibers and a part of lateral pterygoid. Is this resectable or not?
This is the part of this like, anterior component of the ITF that is resectable, sir.
Okay, that's good. So, do you know this subdivision of ITF? Good. Come on, tell us the subdivision of ITF.
Sir, Lyo and all, they divided into supranos and
Yeah,
infranos.
supranotch and infranotch is very easy. Anything else?
And Trivedi and all, they divided into 3 compartments, sir.
Okay.
Low low ITF class 1 is also called the low ITF, and it contained the medial pterygoid, ramus of the mandible, and the masseter. And the class 2 is also intermediate compartment. It's also called the low supranodes. It contained the lateral pterygoid muscle, temporalis, and pterygoid flats, and the third compartment, class 3, is the height ITF, also known as the height sopranos, is contained the pterygomaxillary fissure and intracranial skull base level.
Correct. So this has also been included radiologically. Similar, very similar classification by.
Mahajan and all, they
Absolutely correct.
divided
Very good. Go on, if you can tell us quickly.
So they further divided into anterior and posterior compartment. Anterior height ITF and involved the retroenteral fat, and posterior height ITF and involved the neurovascular mainly structures, and the pterygomaxillary fissures.
Yeah. So low ITF, which is compartment 1. Anterior high, which is compartment 2, which includes a retroantral fat.
Yes, sir.
Posterior high, which is compartment 3, which is divided into 3A, 3B, and 3C, as you said.
Yes, sir.
Okay. Right. So how will you reconstruct this defect? So in this case, you have a predominant bony defect or a predominant soft tissue defect?
Sir, predominant, sir, bony, I will remove segment and all the margin with the only soft tissue defects, sir.
Okay. How do you want to reconstruct?
Sir, because we are removing the part the segment, so I prefer the free fibular flap, sir.
Okay.
But in case of the when I remove for extensive like compartmental ITF clearance, so more soft tissue needed, I prefer the an ALT flap, sir.
Okay. Now, is there any way you can remove the entire alveolar nerve canal and yet preserve a vertical strut of the mandible so that your requirement for osteotomies in the fibula is decreased?
Pardon, sir? Question.
Okay, it's a little complicated. We'll let that be. Maybe sometime else. Okay, so yes, once again, if there is more predominant soft tissue resection, then a soft tissue flap, such as an anterolateral thigh flap,
Yes, sir.
or if there is predominant bone, then obviously bony reconstruction. What are the problems when bony reconstruction is not done?
When we don't do the bony reconstruction, patient may have the malocclusion like
Malocclusion, exactly. Okay. Right. Sunaina, do we have time?
Hello, Gopi this side, sir.
Yeah.
We can continue till 7:15, sir, if everyone is okay with it.
Okay, another 5-10 minutes.
Yes, sir.
I'll let my co-examiners ask.
Lata, so you said your patient is T4B and 3B. So what will be the extent of your neck dissection?
Ma'am, the right side, I want to undergo the modified radical neck dissection, but in one of the our department paper, when we recruit the unilateral unilateral disease with the advanced heavy nodal, so we found the contralateral nodal metastasis, but most of these subsides, when we further analyze, we found in the tongue primary with the heavy nodal, about the 3.3% of the metastasis to the contralateral neck. But in case of the buccal mucosa subside, there's no significant metastasis in the contralateral neck. So for my case is buccal mucosa, so I will prefer only the ipsilateral neck dissection.
Okay, as of today, there is no robust evidence, but you may consider because you have a N3B node in level 1B, even
Yes.
though your primary is well lateralized.
Yes, ma'am. But ma'am, when that paper, when we further analyze the subside, we found more in case of the primary tongue cancer, we found a more significant metastasis to the contralateral.
Okay, right. So in buccal mucosa cancers, alveolar buccal cancers, what would prompt you to do contralateral neck nodal metastasis? Any feature within the primary which would prompt you to do lateralized primary? I'm not saying reaching or crossing midline.
When the patient have the nodal metastasis in the
primary.
Okay.
Skin involvement. There is a paper by Dr. Shivakumar Tyagarajan on this.
Okay, sir.
Yeah. Increases the risk of contralateral neck nodal metastasis.
Okay, sir. I'll read that, sir. Okay.
So Lata, can you quickly tell us like what would be the indications for what kind of adjuvant treatment your patient is going to receive, and what would be the indicators you'd see on your post-op histopath?
On the post-op histopath, ma'am, about the tumor, about the tumor diameter. and subside and the differentiation, and about the tumor depth of the invasion and the margin status, and the soft indicators like the perineural invasion, lymphovascular emboli, and Brandwell-Zensler score, tumor budding reason or not, and about the nodal. For the node, we have to see the lymph node yield and the number of the nodes involved, stages of the level of the nodal involvement, any extra nodal extension. So in my case, when the clinically we're having entry view and histopathologically confirm the pathologic and ENE, so I will prefer for my case adjuvant CT-RT.
What will your concurrent chemo be in this case? What will be your preferred concurrent chemo regimen? What is the standard of care now?
According to the that Burner and the Cooper, that when adjuvant RT plus the concurrent chemo cisplatin, sir.
What type of cisplatin will you do? What will be the dose and scheduling of cisplatin?
Sir,
What's the current standard
3
of care?
weekly, we can give 100 milligram per meter square, sir.
What about if I say I want to do weekly cisplatin, is that justified?
Sir, we can give the weekly dose 40 milligram per meter square. Sir.
Any evidence in favor of that?
Sir, one of the sir,
It's from India.
yes, sir. I forgot.
Okay, there are two trials in this setting. One is the weekly trial from Tata Group.
That trial from our department, from our AIMS department.
No, that AIMS trial is actually in the definitive setting. That is the compare trial. That is in definitive CT-RT setting. It's not the other post-operative trial is from Japanese group. That's JCOG 1008. And that is actually shown equivalence of 40 milligram and 100 milligram. The AIMS trial that you're talking is not in post-operative setting. That is in definitive CT-RT setting.
Okay, sir.
And if today you are asked that if a patient is coming and is affording everything, and if today you are asked that if a patient you have operated and he comes with such high risk features, can you offer him anything else other than the traditional CT-RT? Are you aware of anything that has been published, not fully, but partially at least in abstract form in the last 3 months in such high risk group patients specifically?
Sir, like adding the immunotherapy like pembrolizumab, is patient is affordable?
No, so the specific evidence.
Anything else?
Yeah.
If you listen to Dr. Arvind sir's lecture, the last few slides.
Sir, according to the Keynote trial, the 689, the perioperative, they add the pembrolizumab.
That is pre-op and maintenance. Anything else? Adjuvant.
Sir, adding the nivolumab study, nivolumab, sir.
So what schedule of nivolumab are you aware what they have done in that trial at least? So very quickly, I think it is too much. So they have just given a loading dose between surgery and RT, and then they are given 2 cycles with RT, and they have then given 6 cycles beyond RT. So that's what they have done in that trial, and it has shown some benefit. Of course, the full paper is not available as of now.
Yes, sir. I will read about this, sir.
How will you follow up this patient?
Sir, according to the NCCN guideline protocol, I will follow the patient for the first 1 year, in the 1 to 3 months, and in the second year, 2 to 4 months. And
will you do imaging? Will you do surveillance imaging at first month?
After the adjuvant completion, after the 3 months after the adjuvant completion, I will advise the PET-CT, sir.
After 3 months, we'll do a PET scan?
Yes, sir.
Okay, I mean, that can be
clinical examination plus a PET scan.
And yes, the guidelines do say that. I mean, PET scan, again, we can argue both for and against it in a PT4A and 3B subset. But yes, now most guidelines seems to suggest that even in the post-op high-risk setting, you should do some sort of imaging in the first 3 to 4 months just to assess if we what are we dealing with.
Pardon, sir? Question.
I'm done. I'm Dr. Abhishek, Dr. Smriti.
So Lata, you mentioned about the PET-CT at 12 weeks. So is there any prognostic significance if that surveillance imaging turns out to be disease-free?
Ma'am, that will be the baseline after like adjuvant treatment completion. We want to know the like any other like residual disease or not. So
Yeah,
that
so there are studies which actually tell you that the chance of a patient not recurring within the first 2 years is significantly less when your whatever imaging you do post-treatment. If the first imaging is actually negative, so it actually tells you that these patients are likely to be disease-free within the first 2 years. The chance of recurrence, early recurrence, is less.
yes, ma'am.
Okay, so can you tell me for this stage, if you have a patient for whom you have to do pre-op counseling, what is the prognosis of such patients? Maybe we can end on that question, but uh, what are the typical 2, 3, 5 year recurrence rates and survival rates?
Sir, for the 5 year like survival rate will be the such kind of advice test T4V and 3V the around 40% less than 50%, sir.
Okay.
And
What is the risk of recurrence and when is the recurrence most likely to happen?
likely, sir, risk of the recurrence is the after 18 months, sir. Within 18 months.
Yeah, 18 to 24 months is where most of the recurrences occur.
Yes.
And what is the risk of local and or regional recurrence in 4A, 4B, N2A, and 3B diseases?
Sir, there are very chance of local resonant recurrence in such cases, sir. Exact around 60%. I'm not sure about the exact value, sir, but they have the more chance, sir.
All right. I think you answered most of the questions which were possible within this time frame. Dr. Smriti, Dr. Shweta, if you have something else for her.
I think you did very well. Sorry, Lata.
Thank you, sir.
Yeah, I think so too. I had actually missed a couple of minutes of this, but did you answer Dr. Shwetab's question about adjuvant chemoradiation? Did you tell the exact indications?
Adjuvant, yes, sir. Adjuvant chemo for in
Chemoradiation, yes.
chemoradiation, sir, like according to the Bernier and the Cooper to
Yeah, just quickly tell us.
At extranodal extension presence and positive margin cases, sir.
How about multiple neck nodes? Is that a risk factor? Would you consider, maybe Dr. Shwetab can chip in on this and then maybe this can be the last question.
Sir, this one secondary analysis of this trial, the RTOZ 9501 and URT 2295 and the RTOZ 0234, they found the multiple lymph nodes involvement. The risk of the that is increased till the more than equal to 5 lymph node possibilities.
Good. Yeah, I think now there is a growing body of evidence that we have to move beyond these two subgroups. I mean, in young fit patients, multiple nodes perhaps, and even extensive perineural invasion are emerging as risk factors where we may consider adding some sort of systemic therapy. I think there are latest two updates. One is the RTOG 0920 and the update of Bernier and Cooper also, I think last 2 weeks ago it got published, and both of them seem to point that out. Of course, we have to be wary of the toxicity of adding concurrent chemotherapy to it. But yeah, I think there is at least definitely a subset of patients beyond ENE and extracapsular extraction that may benefit from adding concurrent chemotherapy. That's what current evidence points.
according to that trial, like oral cavity adjuvant treatment, when they compared all these risk factors, this and comparing the standard conventional CTRT with the accelerated accelerated fractionation, they found like not much improvement, but in the advanced test with the advanced with ENE with the advanced nodal involvement cases, they found a significant improvements.
So OCAT again had different issues. I mean, let's not get deep into it because, I mean, for the sake of time, the inclusion and the dose of concurrent chemotherapy both were issues in the trials. So that's why widely it is not so well. It didn't come into practice. But yeah, the broad message is that what with the current emerging evidence, we have to think that perhaps multiple nodes with ENE in a young fit patient, without ENE in young fit patients, and other risk factors may perhaps benefit from adding of systemic therapy to radiotherapy. I think that is where the evidence is heading towards, although the strict indications still remain ENE and positive emergence.
Okay, sir.
All
I
right,
am
sir.
done.
Yeah, go on, Shweta.
No, I am done. I'm done, Dr. Abhishek.
Okay. Dr. Smriti?
So no questions from my side.
All right, maybe we can all rate Dr. Sujalata and let her go. I think you did well.
Thank you, sir.
Even I think you did quite well, Sujalata.
Thank you, sir.
Good, Lata, you have answered most of the questions. Well done.
Thank you, ma'am.
All right. Thank you. That's it from our side. Over to you.
Thank you, sir. Thank you, Arvind, sir, for that wonderful presentation before the case presentation. Thank you, Lata, for excellent case presentation. Thank you, all the examiners, Abhishek, sir, Shruti, ma'am, and Shweta, sir, for your time and rating our Lata for the excellent case presentation. Thank you until the next 2 weeks later. We can meet again on the same platform. Thank you, one and all.
Thank you and bye. Thank you.